care. We've also employed midwives in our practice also. A couple things that I want to talk about today. First of all, I think the best way to frame this discussion today is, have we decided that this is a choice issue or if this is going to be a safety issue? And you've heard everybody talk about their choice of where they want to deliver, and you've heard safety brought up, but I think for the senators here in the group, this is the best way for you guys to approach this topic. Is this going to be a choice or is this going to be a safety? And one of the issues, well, let me take a step back. First of all, there was a mention of the WAC study that was a question about the validity of it. And the problem is, we are right. There are no good randomized studies out there to say, are we doing a good job? Is this a good thing? And so our next best thing is to look at these meta-analysis where you do take all these studies together and you analyze them. And the study did come back and say, yes, there's less intervention, there's lower C-section rates, there's lower epidurals in the home birth versus the hospital. But again, this is a self-selected group that desires less intervention. If you look at maternal deaths, well, there's no difference in maternal deaths. But if you look at neonatal deaths, there is 2 times more neonatal deaths in home births than in the hospital. And if you take out the anomalous babies, the babies that are born with anomalies that are not compatible with life, there's 3 times more death rates in neonates in home births versus hospital births. And you may argue that point, and again, until we have randomized studies, that's going to be the study that we have left to look at to determine what is the safety of home births. The other thing that we need to look at too, and you guys had the conversation earlier this morning with the 2 gentlemen who are coming on the Emergency Medical Service Committee, was transfers. And one of the gentlemen was complaining that it's hard to find volunteers to transfer people or to respond to emergencies in communities. If you look at what the hospital transfer rate is for home births, for nulliparous patients it's 9%. For nulliparous patients, it's 37%. So you have to look at the rural communities where we are, and is this another duty that we want to place on our medical emergency services to transfer moms who are having trouble in labor to the nearest hospital? In rural Nebraska, the other thing that we need to look for is going to be the number of hospitals that are not doing OB anymore. There is going to be a longer and longer transfer time for moms who are having troubles to the nearest hospital. And that's one of the reasons we go to the 18 hospitals. A lot of these places we are doing the shared care with the local family practice doctors. Well, they do the care locally until 36 weeks, and then we take over the last month, so that the transfer or for the driving time for these patients is not going to be nearly as far. There was a question earlier talking about the high technology in hospitals and higher caesarean section rates. And I guess one of the points that I want to make with that is where are physicians held accountable for C-sections and when are they not held accountable for C-sections? One of the problems that, can I go longer?
Sure, just finish out there.
One of the issues that we have is that, obesity is a bigger problem. So when we have higher BMIs, we have higher C-section rates. We have women who had infertility issues who never would have had babies in the past who are having babies that increase the complication rates that they have. And so there are lots of reasons for the C-section rates other than technology. And then the last thing I want to talk about is going to be a quote here. There was mention about how ACOG had a joint statement with the American College of Midwives supporting home births. And I would just like to read this quote. This is from Holly Kennedy. She is the current president of the American College of Nurse Midwives, and this is a quote in an update thing through ACOG, and they're talking about this joint statement. And she quotes here, in response to the writing of this joint statement on practice relations between the ACOG and the nurse midwives, and what I think was a really brilliant suggestion by a member of the team was that this might be a place where we have to agree to disagree, because we didn't want to lose the whole process or have the whole thing go down the drain over one issue. We've each put our position statements and preferred people to it and said we're not together on this yet. This is a pivotal moment where we realized that we could work together between physicians and the midwives, but we could agree on certain terms, and home birth happens to be one of those where we don't agree. So ACOG does not support home births from that standpoint. But we do support working with the midwives and using what they do best in caring for moms in safe situations.
Other questions? Senator Gore.
Thank you, Senator Campbell, and thank you, Dr. Pankraz, for taking the time to be here today. You heard my question earlier about the supervision issue with a licensed practitioner. So what does that mean? You have certified nurse midwives who work with your practice, don't you?
Yeah.
So if you sent that certified nurse midwife down to the train station, I think that was the example used earlier by somebody, with a mother who wanted to deliver in the train station, understanding that your malpractice carrier would probably frown on that, but you could hypothetically you could do that under the law, it appears to me. You just couldn't send her to the home to do that. Is that true? I mean, if there's a train station in Hastings,
in a theoretical situation, I don't know how to answer a question like this. I mean, in a hospital situation, we allow our midwife to work independently. We always have a physician available to back her up. We are in town so that we can respond immediately to her request, but we're not looking over her shoulder. My concern about delivering any place else would be if she runs into a situation in a train depot, I still don't have the services if we have to proceed with an emergency C-section to give the mom the care that she needs.
Could, for supervision purposes though, if that nurse midwife were back at the hospital, and you were at one of your hospitals or clinics away from Hastings, is that still considered supervision?
Not if we're away. You have to have somebody who can respond in a reasonable amount of time.
But is that your own issue, or is that the hospital's issue? You know? I'm just trying to get a handle on what supervision means under the law, and I understand it's you're not in a position to make that analysis, but there'll be others that might be able to help me cipher through that a little later. And I agree with you. One of the things that's frustrating here is with the move towards evidence-based medicine, there seem to be not a lot of studies, and with an increased number of home deliveries, you would think that we'd get a little better at being able to gather that data, but because it's in home, we don't have that data connection. There's no electronic medical record yet that hooks up to most people's homes, so maybe it'll get better in the future, but I understand where you're coming from on that. Thank you.